Morena, everyone. I'm Kirsty Lennon. I'm a GP. I have been a GP now for 28 years. I originally come from Glasgow, although I was born in Nottingham. I just don't say that very often. I've been in New Zealand now for 11 years. And my healthcare home journey kind of started quite early on into Ora Compass's journey, really because I had experience of the model under a completely different name back in Scotland, and that was maybe 13, 14 years ago. So this model has been around, and a little bit the model kind of has changed over time. And certainly it can be different for, in different areas. So I have been also involved in the review of the model on a regular basis. So we kind of undertook the healthcare home journey. And right from the start, we knew that the first kind of version of the model was never going to be the version of the model that we will end up with. And to be honest, it should be a continuous improvement, quality improvement activity for the model, which reflects the fact that that's what the model is. So we are constantly reviewing the model and taking it forward. With the first review of the model, we definitely became aware that we needed to look at the needs for New Zealand, sorry. I'm nervous, and when I'm nervous, my speech of te reo gets worse, so apologies. That it wasn't fit for purpose for New Zealand. So, and equity was really part of that. So with this new version of the model that came out in about October last year, and I'm fairly sure some of you will have seen my face on some of the collaborative videos, etc. The model kind of needed to change with a view to honouring the treaty, as well as an equity focus. And I'm not going to concentrate on the equity focus now because Lance is here and he has way more knowledge than I do. But I have to thank him for the mahi that he put into the change, as well as Fire Merle. Unfortunately, Fire Merle was supposed to be here today, but she's not very well. But she is a huge influence on the model of care, and her input was invaluable. So get well soon, Meryl, really. So we, in order to kind of do the review, we met with lots of people, multi-agency input, plus kind of consumer input. And we did quite a lot of work in the consumer area to kind of review the model and see what needed to be done. And that led to us developing the 7 values that you will see sitting underneath our kawakawa tree. So we have noticed, and these values came out of a lot of work that we did, and Dougal Thorburn really had quite an input in this, and equity is really a real passion of his. So, and that has kind of, and we wanted to integrate these values throughout the model. So that's what you should see, really. And it should be about entrenching the equity focus throughout the model. The language should be appropriate for New Zealand, and it should be that it will make a difference. Because the model's only come out October, we're still in the early stages of seeing the value of those changes and what that might mean in the future. So, so you've already seen this. Mably's spoken quite a lot about what the model looks like, and I'm sure you've all taken time to kind of read what the characteristics are and what that looks like, and the 4 kind of areas that we need to concentrate on. And again, this is not perfect. This will be reviewed again, and it will change again. It needs to. We're not going to get it right each time, but a bit like healthcare homes who have to constantly change, and we're constantly looking for quality improvement. We are going to quality improvement the model again and again and again. So, but we have picked out some of probably the key features that kind of came out of, which probably kind of is the ethos of healthcare homes. those include things like the continuous quality improvement, and sustainability got moved to, it used to be urgent and unplanned care was the top one in the model, and we moved it. And we moved it because sustainability is probably key. You need to have sustainable practices in order to run out the rest of the model. So sustainability became like the top priority. So things like continuous quality improvement, crucial and cultural improvement, same. And then we kind of thought, well, yes, the next kind of level is the telephone assessment and treatment. Now we're going to talk about that. I'm happy to take questions throughout when I'm speaking. If we get stuck on that area, because that is the area that we get most questions about, we might move on and talk about it a little bit more at the end, but please feel free to interrupt and ask. But it's often practices who also struggle with that as the biggest change. So that's why we're going to kind of speak about it quite a bit today. Then there is the stratification of patients, which Mably talked about, identifying those of highest need. So those highest need patients often take up 40% of the health budget. So that's top 7% are usually using 40% of the resources. So they need to be prioritized. And Mably will go over that, not Mably, Mel will go over that this afternoon. Also, the need for care planning. So Mably did refer to Year of Care. It has changed. It's the HORA Wellness Plan, and that was to fit with our equity focus and the appropriate language for us. And it is also going to be based on the Tafara Tapu Far model for Maori Health. So it came from all the mahi and the kororo we had. That was what came out as a priority, was that actually it should be a culturally appropriate care plan. So hopefully Mel will speak a good bit more about that this afternoon. Also improving health equity, cultural needs and cultural safety, the alternatives to in-person consultations, which we're going to talk more about today. We're going to talk about the portal as well, and a little bit at the end about virtual consults. A fully functioning portal probably runs through quite a lot of what we do and around both efficiency and is kind of one of those key factors into changing the flow of work. Patient engagement also is key. So this was quite new to the new change in the model, and that's kind of being rolled out at the moment. So actually asking your patients, actually saying, what do you want? What do you need? Particularly your high needs patients. We need to ask. If we don't ask, we're only guessing. So you need to ask what they need. And in fact, one of the practices has already started this. They invited a bunch of their Maori patients and Pacific Island patients in for a little bit of kai and a little morning tea, and actually just had a discussion with them around what is it we do well, what don't you like, why would you not come, why would you come, and just got a little bit of those kind of ideas from their patients about what that might look like. So again, it's key to making your service appropriate for your patients. And the call demand monitoring, Mably spoke about this, it is kind of a priority. I think for the first 4 practices, it actually became apparent that if you don't have that, you don't get your data, so therefore you can't make change because you don't know. Again, you don't know what you don't know. And some of them needed to change their telephone systems. And that was quite an early learning point for all the practices, was we didn't have an appropriate telephone system that would give us the information, so therefore we needed to change it. Some of them changed to VoIP systems, etc., so that they can collect the data that they needed. Okay, so what do the practices strive for? Yep, Mably kind of went over this. Person-centered, not disease-centered. continuous relationships over time. And I know in this world, you know, lots of us work part-time and we're not there all of the time, but that can be improved with things like the portal. It also has improved with things like team building within a practice. So a lot of practices have set up little teams so that if the doctor's not there, there's a nurse attached or another doctor that's available. So they've kind of formed teams so that the patient, it's not just one person the patient has in their team, it might be 2 or 3 people that they know they can contact if there are problems. Coordinating access to other services. And I think there's a huge opportunity with community health networks around the integration of primary and secondary care. I think we all kind of find that quite a barrier at times, and I think there is opportunity, and that will be probably within the reiteration of our next kind of reiteration of the model is around you know, what that would look like. So the community health networks are another step, but beyond that is also that kind of integration with secondary care, particularly around communication and virtual care. I think virtual care holds a key to kind of helping that move forward. And comprehensive, so for providing most of the care for most of the people that need it for most of the time, and for that care to be delivered near home. Not distantly. It is an ethos. It is about change management. I was very lucky very early on in my career to really kind of have a bit of a mentor who basically kind of put general practice in the context of business and the fact that with businesses have to change constantly. You know, you will not survive in this world if you stay exactly the same. And practices are very like that. If you don't change, you will not survive in a changing environment. And we're in a constantly changing environment. And so this model kind of is to help that. It's to help people to learn to problem solve, to learn to learn. Learn to change is actually a biggie. As Mably said, change management is actually quite difficult. And it is learning that, how to help others to change. And it's not really about being different, but it's about doing things better, okay? And that's based on data collection, and it's also based on getting information from your patients. So taking the patient test. So Andrew up in Northland, he kind of spoke about this at the symposium, is it 2 years ago now? Oh goodness, yeah, 2 years ago now, where you take the patient test. So that basically is what you're doing defensible to the patient? Not from the point of view of legalities and that kind of thing, but more of, are we actually providing you with the service? Can I explain why we do this? And I think if you can aim to kind of hit most of the patients, 85 to 90%, you're never going to be 100%. And I think that's the case with anything, isn't it? You can never be 100%. But if you can do it most of the time for most of your patients and provide a great service, then you're doing it right. Okay, so let's move on to phone assessment and treatment. Please be aware, I may well call it triage. We are supposed to call it phone assessment and treatment, but that's such a long phrase. So if I refer to it as triage, please, I apologize. Triage really came out of field medicine, didn't it, and war, and this is not what we're dealing with. We're not dealing with a war. Just be aware that my language may change a little bit as I refer to it, just because it's a quicker, neater word to kind of say. So we're in the domain of urgent and unplanned care. And so there are 4 kind of characteristics in this domain, but I think the one that we need to probably concentrate on is the telephone assessment and treatment, and that's the patient needs assessed via triage. And it goes from it's not done to it's done in a systematic way throughout the day using a clinician who can diagnose, order investigation, and prescribe at times of heaviest demand. And the triage system supports continuity of care where possible. So what does that look like? Yeah. So So that just says, why are we doing it? Why are we triaging? So as we are aware, demand is increasing, and demand for on the day is increasing. And we're all aware of shortages of GPs and nurses that are going to hit us increasingly as the years go on. And so we need to find a way to manage some of this. And by managing our acute demand, we can manage our day much, much better. There are such advantages in doing it, both from a patient point of view, but also from a clinician point of view, and how your day runs. It's kind of key to making any other changes, because if you can change your workload and your flow throughout the day, then you can start to concentrate on other things. We all know if we're firefighting every single day, all day, you don't get anything else done. You don't tackle anything else. So this is in key to where we kind of start. So yes, you do need to have a sustainable practice, but this is probably one of those things that needs to start within the first few months of your healthcare home journey. It values patients' time. It increases the capacity to cope with acute demand. It provides other options for access to care. It frees up time for proactive and planned care. It improves the business efficiency and is enabling patient choice. Excuse me.
I think the other thing it does, Kirsty, is it allows for continuous care. Because
I agree.
The person answering the phone can see that somebody's got a provider or somebody's dealt with this before, they can allow for continuity in that space.
I think that's true, yeah. And I think that's key to good triage. And in fact, probably, I'll speak about where I kind of see the gold standard of triage might be. So if a GP is sitting, answering phone calls, not necessarily GP, but also nurse practitioners or clinical pharmacists, are answering calls at the peak of the call demand. So usually it can be between 8:30 and 9, but it can also equally be 10 to 10:30. If they're sitting answering all the calls that come in at that point, where they can answer, and on average we're looking at maybe about 20 to 30% of the daily demand if they sit on the peak of the calls, and they are triaging at that point, they can manage over 30% of their patients with other than face-to-face consultations. And you don't limit the number of calls. So practices are doing it differently. There are different models, and I'm not saying this is what I would see as the kind of gold standard of kind of giving that service. They're answering as many calls as they can in the time that they've been given, and that can be between 3 calls, or it can be 5 or 7 calls. And if you can manage that, and you've got slots to put those patients in that you do need to see, so your template reflects the data and it reflects the need, then that will make your day run so much better. The patients completely value the service. They value the fact that you're, valuing their time and that they don't necessarily need to come in. Do I think it changes the quality of care? No. And COVID taught us that, didn't it? We sat on the phones, we dealt with 80%. We didn't manage all of the demand. COVID did not allow us to do that. And I think we've seen the rise in consultations post that. But if we can manage that kind of with calls, not the face-to-face, then I think we are offering a much better service. And patients saw the advantage of it as well at that point. So I think you can, COVID kind of was part of what we were. It helped, sorry, I've lost my track. Healthcare homes, actually, the healthcare home practices in CCDHB responded to COVID way better than the practices who were not healthcare home. And the reason they did that was because they had ability to change. they had a previous experience of offering other than face-to-face consultations, and they ran with COVID and they did an exceptionally good job. And I think even Jess would say that you went to practices at the time and it was the healthcare home practices that thrived in that area.
Yeah, to upscale quickly.
Yeah. This is kind of an average practice, well, a practice of 10,000 patients. We have a few of those in Wellington, but not huge amounts. They would be expected to have 30 to 40 calls a day. That would kind of be the average. This is very measurable. It's very measurable, and it's quite similar here than it is in the UK. The pattern of how patients phone and when they phone is actually very measurable. It's very replicable, as in that it's the same. It changes slightly over winter than it does in summer. Say for the Coromandel, where potentially they have an influx of people, then it might look a bit different. Or for our low-cost access practices, they find they have a bump on a Thursday. Not very typical, but typical because everybody gets their money on a Wednesday. So it is individual to the practice, but on the whole, their data will be, it's the same week on week on week on week, and year on year on year. It will always increase slightly, but you just keep measuring and you keep responding to that measure. So it's the data collection that's really, really important. Have we got those graphs? Yeah. So this is quite, this is somebody else's data. So very typically we'll have a peak on a Monday. Oh, yeah. You know, no brainer. Of course, everybody phones on a Monday. This is actually quite unusual. I find that most practices also get a little bit of a lift on a Friday. Pre-weekend, you get a bit of an increase in the number of calls that come through. But it's measurable, okay? That's why you need the phone data, because the phone will give you this information. So phone matrix will tell you what day patients are phoning and what time of day they're phoning. So for some practices, yes, it's between that 8 and 9, 10 o'clock in the morning. That's the peak of their calls. For other practices, it can be 11 o'clock. The low-cost access practices, they have time-rich patients. They often don't phone till a little bit later on, but it's responding to the data. It's collecting the data and then making your plan accordingly. There's no point putting a GP and a nurse practitioner on the phone at 8 o'clock in the morning if your patients don't phone till 11. And this is the yearly collection. So you can see there's a dip through the summer. COVID kind of screwed some of the figures that we've got. But on the whole, this would be the average year. We have to kind of take COVID out of the picture, but this would be a typical pattern. And again, it would repeat year on year on year. Yeah. Thank you. Yeah, let's go back to the telephone script. So it is important that this process is leaned. So standardized call handling for patients requesting same-day appointments. And I do think you have to run that all day. Triage runs all day, so consistent with the processes for patients and staff. Making it easier for call handlers to have, you don't need to negotiate with the patient. I have to say that if you get a horrible, not a horrible patient, but a patient that this is not suiting for, sorry, that was really not the best thing to say. If you get a patient who's a little bit, oh my God, I've got to go and do this and this today. I can't wait for the doctor to phone me back. Just give that patient an appointment. Don't go into that negotiation. It's not worth it. Those patients are very few and far between. For most of us, it's absolutely, they would be very happy to speak to the doctor on the telephone. So let's deal with those patients who can be dealt with that way. Just don't fight the fight. Okay, so although it does say no negotiation, it does mean no negotiation in that actually if the patient's not happy with that process, just, let them have where what they're having. It is honestly very few patients. The patients completely value this as a service. Should be a simple script at the front desk and for the triage providers. So everybody who's providing triage has to kind of check, is this the patient I should have phoned? Is this the right number? Are you the patient that's on my desktop? Yep. And the data, yeah, you just really have to really kind of use the data to match the supply with the calls, but also with what's on your template. So your templates need to reflect the data. So if you have 30 calls coming in through a day, and potentially you can deal with a third of those, so 10 of them, via the telephone, then you will still need 20 appointments, acute appointments available that day to deal with the other patients who can't be dealt with. And remember, it's not just the time when the GP, nurse practitioner and the clinical pharmacist are on their phone. That's the triage that goes on all day. So there's still triage all day. So you have to provide appointments for all of that on the day demand. You're not going to get it right 100% of the time, but the data collection allows you to get it right most of the time. So what does a kind of phone call look like? Yeah. This is kind of key, isn't it? What happens at that front desk, that first contact with the patient? Most patients will say, hello, can I see a doctor today? Yes, okay. We're offering a new service. Yeah. You know, the doctor can help you on the phone. You may not need to come in. You just have to develop your own. This is just an example, but it's important the practice has that conversation. It's important that the leaders, the clinical leaders within the practice are also talking about the why and the how and how this is going to roll out and what do you do so that everybody is on board, so that the patients get that consistent message of what's happening. And it's kind of important to almost advertise it before you do it as well. So if you kind of put out on your Facebook page or your website, you know, this is a new service we are developing. This is going to start on this day. So some people don't do it all in one go. That's the other thing. Lots of practices run it out a little bit at a time. So it is such a big change. So in Raumati, where I was working when we first started the healthcare home journey, I did it first. The other clinicians realised I was having a much better day than they were. So quite quickly, the other clinicians became part of that picture. So, you know, you just have to, you can start slow or you can start with a big bang. It really doesn't matter. But if you've got someone who is a little bit of keen, happy to do that, and there are doctors who are not happy in this space. We do definitely have doctors who just, this is not their comfort zone. They require visual cues to treat patients. That is not worth putting them on the telephone because they're just going to bring everyone in because that's not their comfort zone. It's okay. It's okay. But for most doctors, and especially I think now with the experience of going through COVID, you have to say most doctors are now going to be more and more comfortable with speaking to patients on the telephone. It was kind of part of our job anyway. We used to phone patients all the time. Maybe not for the acute thing, but for lots of other reasons. So, and often you're providing information or, you know, an assessment over that telephone at that point. So the next key thing is you must take a telephone number. Everybody needs a telephone number. Which number are you going to be available on in the next half an hour? The doctor will phone you back on that number. What's that? Yes. Okay, can I just check with you this is the number that we can get you at? So lots of people do not answer numbers where they don't know the recognized number. You just have to tell them, look, it'll come through as an unrecognized number, but the doctor will phone you in the next half an hour. most of the time you will get that patient. Some of the time you won't. So you do need to develop also a kind of protocol. What do we do with that patient? If I phoned them and I can't get hold of them, what do I do with that patient? So often you can try again, or you can pass it on to the triage process that happens after the kind of peak calls. Huge advantage. The patients love it. Okay. So what does resolution look like? So the patients can be resolved on the telephone. They might not be resolved on the telephone, in which case they may need to come in the same day. They may need an appointment within 2 to 3 days. I think there are kind of 3 lots of appointments. There's an acute on the day appointments. There are appointments that could be available within 2 to 3 days. And then there are routine bookable appointments. But I think you have to be mindful of that when you are setting up your templates, that you actually need a little bit of a variety of appointments. Because some patients, you actually want them to go and get their blood test, or you want them to get an x-ray, or whatever it is before they come to see you. And you need time for that to happen. And we do find there are patients who don't necessarily need to be seen that day, but need to be seen within a certain length of time. Now, the ideal is you've got that time to next available appointment at 2 to 3 days anyway. But until you probably do that, you probably need to kind of set your template up. Okay, so patient portal. I think we have one practice with when they have had a huge number of patients signed up to the portal, that actually the portal also has a role in dealing with acute demand. And I think once you hit 40% of your population, the work shifts. Yeah, for sure. But I'm not going to talk particularly about triage. The portal on the whole should not be considered an acute tool, should not be for urgent and unplanned care. And I think most practices do kind of fit it with that. Really because of lots of part-time workers, it's not answered all of the time. So just, I think most of us find the portal sits in the kind of routine and preventative care domain rather than the urgent and unplanned care domain. But obviously, I think, you know, there is stuff that comes through. I think you just need to be aware of it. But I think most people on their portal have something around, if this is urgent, please phone the practice, rather than using the portal. Okay, so Mably spoke a little bit about this, so I am not going to go on too much about it. But basically, the portal does kind of cover a lot of the characteristics within the healthcare home model. There are many kind of areas where it benefits. And of course, there are different aspects to the portal. There's prescriptions, secure messaging, looking at results, recalls, booking appointments. I think texts should slightly fall in the same bracket as patient portals as another communication tool. I think lots of us now use text messaging quite a bit. Certainly, it is a huge advantage, I find, from the point of view of not chasing patients, being able to kind of communicate quickly, getting a message across fairly fast. And the big one is open notes. So Mably has told you the figures for CCDHB, where and over the whole of New Zealand, there are now 682 practices with the portal, and that's covering over 1 million patients are now on the portal, are now using patient portal. So registering and using are not quite the same. Yeah. So I believe you can get figures about what's happening, and we do monitor that for our practices. They can tell how many patients have requested prescriptions, how many emails have come in, how many emails have gone out, that kind of data. So again, data collection, it tells you exactly what's happening with your portal. So Manage My Health has figures within it. I'm not quite sure how Indice does it. I think it's probably on the dashboard, but it does collect the data. So yeah, they're becoming increasingly important. Our prescriptions do not touch a nurse's hand. Never. They come in the portal, or they are sent directly to me from the front desk, and I am responsible for that prescription, so I'm the one who is signing it. And with EPrescribing, it's so much easier for me to go in and just do the prescription and send it. It's cost effective. Why should it touch 3 pairs of hands when it only needs to touch 2, or even 1 from the portal? It does, it's such an efficiency. So yeah, I deal with all my own prescriptions, and so it is a huge kind of change in the workflow. Okay, a little bit about telehealth, embedding telehealth. Okay, so we have all kind of been starting to do this. COVID definitely made us start this. Doxy.me must have had a big spike in their shares. So yeah, the alternatives to in-person consults. The advantages around that time management, isn't it? It's time management both from a clinician and time management for the patient. Do they need to take time off work to come and see you? Actually, are you actually going to examine that patient or not? One practice is using this very much in that returns space. So using the patients that have come to see them, but then you've examined them, and the follow-up appointment is the one that they have focused on doing virtually, whether by telephone or by video. And that's actually a good starting space, isn't it? That you've often done the work, you've done it, you just need to have a conversation back with the patient around where do we go next? What does this mean? What are we doing? It's not for everyone, but it definitely can be really valuable to some patients. And we have a whole bunch of 18 or 19-year-olds up in Waikanae, and they actually took to this very well. The old silver surfers were very good at virtual consultations, I have to say. We have Indice, so it is actually quite easy because it's integrated into Indice. Any appointment can be booked as a video or a telephone consultation. It's you just click through on the little camera and it takes you straight through and it opens it up, and there you go. What we did find was sometimes the patients, their knowledge around potentially their browser may not have allowed the communication. Chrome worked way better than some of the other browsers that you get. But it's an area of growth, and kind of technology is catching up with our needs really in this space. But I think it's completely an appropriate way to manage patients while valuing their time, really. Yeah. I think that's probably us for this morning. The only thing I probably haven't said, and Amajit will probably tell me I should really have said, is that obviously healthcare homes does now align with a lot of the characteristics in the domains for Cornerstone. And we've mapped that across, so there is a crossover with that. And also we feel that our new focus on equity does align with the Simpson report, the Health and Disability report that's come out. So I know also the kind of Ministry of Health, PIOTA, Healthy Futures, we feel that we have aligned with a lot of that. So I think healthcare homes is definitely, at the leading edge of some of the changes that are coming. And I think the one thing is definitely that our healthcare home practices get so used to change that they keep changing. So I think when we queried, what does the future look like? What support do those practices need? Actually, then it becomes the built-in ethos. So they continue to change. They continually look at their data. They continually improve. And there's definitely healthcare homes, you will see there's like the characteristics are set in 4 grades. Well, there's actually a 5, 6, and 7. There are improvements to be kind of beyond what we have set. So it's not that when you get to characteristic 4 and you've got all of your characteristics at level 4, that's the end of your journey. It definitely isn't the end of your journey. It is just a process to will teach you some tools to take on for the future as well. So yeah. Anything else anybody wants to ask me, because I'm going to go home. So.